Okay, thanks everybody for coming. This month's lecture is my spine is fused, my neck or back or arms or legs or whatever extremity you want to say hurts. I thought you fixed it. What's going on? So that's like a common question. And I like always to do illustrative cases. So this is case one. This case will go into depth. And we have 3 or 4 other cases we'll do quickly if we have time. But I like to go into one case in great depth because I like doing that. That's fun. So this patient's a 61-year-old woman who presented to my office with axial neck pain and right upper extremity pain paresthesias. She's had these symptoms for about 6 to 12 months or so and is on many medications to try to help it, such as Neurontin, Lyrica, different various sizes, shapes, and deliveries of opium and muscle relaxers. Yeah.
Axial neck pain.
Oh, so axial is dead center. So dead center in the neck, like where you would think the spine would be.
Okay.
As opposed to other areas are. For me, it makes a difference as a spine surgeon where the pain's coming from. So let's say I ask them point with your one finger, with your index finger, and if they point to the trapezial area, that for me is different than dead center, middle of the neck, versus in the front of the neck. Nobody ever points to the front of the neck. Trapezial area, I'm thinking it's more radiculopathy type pain, not disc or facet pain. The other thing is periscapular pain. People say it's neck, but it's actually periscapular pain, which could be referred from the facet. So this is more of the art of spinal surgery, but I like to think about it because there is some fact and science to it. So when I say axial, it's dead center spine, and you're like, so what? Who cares if it's axial? Well, if it's axial, then I would think it's more maybe if it's a facet pain or disc pain, but it also could be stenosis pain. But axial is definitely not radiculopathy type pain.
Okay.
Does that make sense?
Yeah.
Would you agree with that, Doug? Okay, so back to this patient. So she has a past medical history of a C4 to C6 anterior cervical discectomy infusion, and then the plate was removed. I don't know why. And then she had a C6, C7 ACDF, anterior cervical discectomy infusion, and then she had a C2, C3 posterior spinal fusion. And all of these surgeries were between the time period of 2000 and 2009. I believe, in Georgetown, I'm not sure. And the patient cannot recall exactly why these surgeries were performed and in what order, but she knows that they were done. So her exam is basically a non-focal exam with no deficits other than pain and restricted range of motion of her cervical spine and some ataxia, some mild ataxia. So does anybody want to know any other history in this patient?
She smoke?
Non-smoker.
Non-smoker?
Mm-hmm. And healthy woman, actually, no medical problems. Other than I think like low thyroid, something like that.
Because it looks like she has a whole bridge, mouth of bridge work.
She does have, yeah, she must.
Mm-hmm. Looks like she's, might have some type of underlying metabolic bone disease.
Possible. So, so any other questions? Clinical questions? Okay, so Adam, what do you think of the X-rays?
Well, I think the alignment is good. That we can, up to the levels we see, the alignment is good. The fusion at 4.5 appears good, solid, well aligned. The anterior fixation plate at 5.6 is in adequate position.
Now hold on a minute, Cowpoke. This is C4, C5, and this is C5, C6. There's 2 levels, and this is C6, C7. Yeah,
okay.
It's a little bit hard to see, but. So you think C4, C5, and C5, C6 look solidly fused?
Yes.
Okay, and then C6, C7, what did you say?
It's not solidly fused, but it's ossifying, or it could be. It could be solidly fused, but it is definitely ossifying across the disc space, and it's in a good alignment, and the screws look good, the plate looks good position. Mm-hmm. It doesn't see any sign of loosening.
Okay, doesn't, right?
The posterior fixation more cranially also, maybe that the inferior screws there are somewhat superimposed over the facet. Mm-hmm. Or not the facet, sorry, the foramen. But then again, it's very hard to see the foramen on the lateral. You really need the obliques for that, not the C-spine.
But this screw, you're right, it may be going through the facet. And is that a problem, you think? Or it's like, it's okay? Have a screw go across the joint?
I would think it would enhance it to fuse, having a screw going across. But it would probably put excess stress on the screw to break, to become loose.
What do you think, Doug?
I think it would hurt.
Right, so if you put a screw across a joint that's moving, it could be a source of pain.
And then,
Just so you know, we do that. No, not on purpose, but we do that. When we put a screw across a joint that's not fused, it hurts.
yeah, and I'm going to disagree with Adam about C6, C7. First of all, I don't think the term is ossifying. And to me, that looks like there might be some dead bone from a graft in there.
Okay.
And so I'm not sure if it's doing anything. It's the dead bone sandwich is what we call it.
Okay.
It's like good bone and good bone. But it's tough from...
But we think differently, you know that.
Yeah.
Orthopedic surgeons,
Yeah.
we have different brains than you guys, totally. Okay, so Doug is very suspicious here at C6, C7 that it's what he's saying, non-union. Anything else you want to add, anyone? If he's a front view.
Is that screw back down? C2? No.
Man, he's very astute. What do you think? Let's throw it back to the radiologist.
Yeah, the head is
It's an air ball.
the head is superficial to the plate, so it's backed out.
It's a locking plate. I almost can't tell if it has...
I can't tell. Very good. How about, I just have one question, and I don't know what this is, and I'm not being
There's
just...
surgical clips in there.
What is that? Surgical clips?
3 surgical clips.
Yeah, look,
Those are just surgical clips.
one up above, too.
Yeah,
up there?
Above
Above.
or wires up above.
Okay. All right, I'm just curious. I don't know. I think I may know what it is, but I'm messing with you guys. But, okay, next. What do you think here?
So now we have the oblique views, and the upper screws, the posterior fixation, do not go into the frame.
Okay. See the frame right here? Is that what you mean? So that hole, I don't call it framing anymore. I call it the hole where the nerve comes out.
Okay.
But you can call it framing. So the framing, the screws are not in there.
Right. And
So
they look wide open. They're
Okay.
very, very healthy
okay.
framing.
And what?
And then it looks like several of the screws are from these projections are backing out.
They should be flush with the plate, right?
Yeah.
What kind of plate you think this is, Doug? Now that you got a better view.
I think I figured out why they took that other plate out years ago.
They used the wrong plate.
Yeah,
No.
to me that they look like recon plates.
They really do, don't they?
Yeah.
They're Synthes Recon. They're Synthes DCP plates, actually, I think. It's okay. What's the big deal? They work.
If they're DC plates, here you go, Spiro. It's not DCP plates.
Dynamic, what is it?
It's DC plate.
They took out the P? Oh, yeah, you're right. DC, Washington, DC plate.
So it depends on the thickness. Some of the recon plates, they make them so they bend, and there's sort of like a joint where you can break them. And if they're recon plates, they will break or they're not terribly strong. If they are DC plates, depending on the thickness, they have all sorts of crazy plates now. But
So what
it
is-
looks a little suboptimal. The screw heads don't look like they fit flush in the screw holes, number one. A lot of times the plates now are designed where the head locks into the hole. Well, number two, it looks like all the screw heads, or 3 out of the 4 screw heads, are a little bit
They're not flush, are they?
loose or eccentric or have moved.
They're not flush to the plate. Now, if you're like Sherlock Holmes and you're always thinking and try to understand things, what is this? Why would there be a DCP plate in the neck? Like
The DC plate
DC plate,
in the neck.
yeah. Like most spine surgeons use what now with posterior fixation? They use posterior cervical plate and screw systems, or basically they're rod and all spine surgeons now use screws and rod systems. So why would? What is this? What does that tell you? Like what's?
That's old.
This
You're a little
is not
suspicious?
Spine surgeon.
Something is suspicious here. Either the patient got it wrong, and this surgery was done in 1985, which this was very common to use these plates because there was no good plate system, Or the surgeon who put it in is an old surgeon, and he's like, I've been using these plates for 20 years. That's what I'm using. What do you think?
You know, I wasn't even aware that they were 85. You know, in '85, I thought most people were like wiring for sets. You know.
No, they used that. This was very common using the Synthes, and that's when actually 95. When did DC plates come out? Like 90, wasn't it?
Earlier than that.
No, 85. That's why I think this.
Compression plates have been around for a long time.
So this may have been done by a 60-year-old surgeon, maybe, who was comfortable in 1985, because it just doesn't smell right. It's kind of a little bit weird. The stories, or maybe the patient got it wrong. Who knows? But something's just not right. Anyway, we're getting off point. How about
They do in Georgia.
who knows? No, this was in Georgetown, and they're
Oh,
good.
Georgetown.
They're good surgeons at Georgetown. Yeah, that's a good institution. And what about this anterior plate? I mean C67. Any other comments?
There's some sclerosis at the end plates.
Okay.
It doesn't appear fused.
Okay, and it doesn't.
Ossifically fused.
Why don't you think it's fused?
There's lucency, at least on the right image is too blurred and just.
It's hard. It's not good X-rays. Yeah, I'm
the
sorry.
left image though, there's lucency. Or
Right here?
The image on my right, sorry.
Right here?
There. There's lucency.
Black line.
Yeah.
Okay. All right. There's a black line going through there, which would mean the bone's not fused. The other thing is, I found the oblique views give you a really good idea whether the patient's fused or not. And as you can see here, it looks like a solid fusion. But we already said that was fused. Okay, let's go on with the X-rays. So, this patient has failed all non-operative measures. So I ordered, and she looked into it. She wants this problem fixed. She can't deal with it. So I ordered a CAT scan. So what do you see here on the CAT scan, Adam?
So this is a coronal two-dimensional reformat, and you can see the odontoid on C2 to help you know exactly where you are.
Mm-hmm.
So there's 2 and 2, 3, and then 3, 4, and then you can see 4, 5, and 6 are solid bone. You can see the holes from where the plate was, or the screws were removed.
Mm-hmm.
And then you can see that there is sclerosis and lucency at the 6-7 level, so it has not ossifically fused.
What is this, Adam?
That's some metal, volume averaging with some metal that is sort of...
This thing right here?
Yeah, the hyper bright stuff.
This thing is metal? These are the screws.
Yeah.
And what's this?
That's part of the plate, I think, that you're volume averaging with the plate, that there's a little piece of it in this slice of bread, kind of like if you cut raisin bread and you get a piece of raisin in one piece and a piece in the other piece.
It could be, but I know what it is though, because
That spacer, something. put
yeah,
in this.
it's an inner, and what can, so what do you think it is? I mean, you're right, it very well could have been that, but it's not. And I know this case, that's why I say that.
All
So,
right.
so it's a spacer.
Disc spacer, metal. liquid
Yeah.
Disc space.
So it's metal, but what do you think it is, Doug?
Is it like a cage?
No, it's allograft. It's a piece of cortical allograft.
Did you say it's metal?
It's cortical allograft.
Oh, yeah, that's what I thought it was originally.
I know because I took it out.
Yeah.
But I'll show you some more images. So,
Dead bone.
so the sclerosis, yeah, it's a dead bone sandwich.
bone or
It's,
something.
it's cadaveric bone, yeah. So you see this sclerosis is what Adams was talking about, and this is the lucency. And Doug, what is that?
The lucency?
Yeah, what is this sclerosis about this joint?
It's a non-union.
And it's a non-union. And why didn't it fuse?
There's any number of reasons. You always have to consider that it might be infected. Someone who's been multiply operated, and they have dead bone, they have infection. Or you're putting a non-biologically viable material in there, and you're not...
It's allograft. It's viable. I mean, it's
depends on how it was treated and processed. And
allograft. Everybody knows is dead person bone, right?
And then it depends on whether the bone ends were prepared properly. You know, if you expose cancellous bone, or if
What do you have to do? Tell everybody what do you have to do to prepare it.
you have to you try to decorticate the bone. So like the ends of the discs, you know, in pristine area, they're smooth. They have cartilage on the end of it. You have to remove the cartilage.
So you take the cartilage away, and then there's one more layer you have to take away too.
Some of the cortex.
Cortex away, and then you get down to what?
You try to get down to cancellous bone, or
Cancellous bleeding bone.
Bone.
Why do you have to get down to cancellous bleeding bone?
that's where That's where the cells are that assist in healing or fusion. Primary bone fusion as opposed to ossification. And I think the difference is ossification is actually primary bone healing on a matrix, where this cartilage lays down, which is ossified. I don't think this is called ossification. I think this is...
I'm not sure if I agree with your wording, but it's okay. But that's great. We're going to get into this more.
Like soft tissue ossification, heterotopic ossification is something, is bone forming where it's not supposed to be bone.
Okay.
We're going to get into this. We're going to get into this in great detail. So that's the only reason I'm cutting you off. There's going to be a lot of better slides. But okay, so this patient, so why wouldn't the surgeon prepare it well?
Just motion at this level. He's moving where she's moving.
That's a very good point. What Doug, when you think mechanically, is this an easy one to get to heal, or is this a hard one to get to heal? C6, C7.
It's a little bit harder.
Because it's at the
More
very
motion.
base of a very long
Right.
fusion area.
It's a lever on.
It's a big long, so her whole spine is fused from C3, from C2. Well, C3, C4 is not fused. That's the only one that's not fused. But this whole thing is really stiff, so there's not much areas to move. So it may be still micro motion. There'll still be some micro motion there to get it to heal. It's very hard to get long areas to heal. Does everybody understand that? It's kind of like working. I tell patients working on the base of a tower. There's a lot of stress on that level. Okay, so that was a good discussion. So here's another view that you can see the allograft lucency all around it. And what travels right here, Mr. Adam? Vertebral artery. So it's really close to where the surgery is, right? Here's some more. What do you think of this, Adam? Anything to add?
Still non-fusion at the...
See this
6, 7
lucency that goes all across? So is here to here fused?
Can't tell because
How
it's
about-
so white.
Okay, I'm going to sorry to
Yes.
disagree with you, but let me tell you what I'm thinking. I think that's fused. So what happens is usually the whole thing is not lucent. This doesn't fuse, and here's the non-union area. And usually there's only one non-union area. There's not like multiple. If I saw lucencies above and below the implant or the allograft, I would be worried about infection, like Doug said. But in this case, this is how non-unions are. So it fused here, but it didn't fuse here. And anything you want to add here?
You see the superior the sclerosis at the bottom is C6.
C6, C7,
Yeah.
and there's a lucency across it. And this looks solidly fused, doesn't it?
Yeah.
And C3, C4, any comments on that?
You know, the rest of her spine looks pretty good. I mean, the neural elements look really good. She doesn't have considerable narrowing that I see on this image.
Okay.
So her alignment seems to be great. She doesn't have any disc bulging.
What about C1, C2?
Some sclerosis there, cortical thickening. Which I relate to just stress response.
Anything you want to add here, Adam? This is another sagittal clip.
Non-fusion.
Doesn't look like it's healed at all, does it? Adam, I want to ask you, is C2, C3 fused?
Yeah, posteriorly the facets are fused.
Looks solidly fused, doesn't it?
Yeah.
There's the facets. And what is this thing? Is it so did they put the staple inside the facet? See that dark thing?
Yeah, I have no idea.
You have no idea. Me too. I don't have no idea. Remember you said that the screws in the facet, you think there's still the screws in the facet here?
It looks like it's proud into the joint. It extends out into the joint.
Pretty close, right?
Yeah.
Yeah. So this is in what joint then? This screw is in what joint? This is C2, C3.
C3, C4 facet.
So there's maybe a screw in the C3, C4 facet joint. And is C2, C3 fused?
Yes,
And what do you think of C6, C7?
not fused.
And how about this? Is this posteriorly fused?
Can't tell. Probably not.
That's fair enough. All right. What do you think of the MRI now, Adam?
So the MRI shows the 4-5 fusion. And I guess we decided that was 4, 5, and
4, 5, and 6, yeah. How about 6, 7?
6. That is 6 right there.
This is the body's bottom. This is where the out 6, 7 area.
Yeah.
Anything you want to add? Spinal cord compressed?
No.
What about this?
little disc bulge, not much. Nothing significant, probably.
Okay, I'll take that. And C2, C3, how's the spinal cord look?
Fine, great. Surrounded by CSF and a susceptibility artifact from the hardware and the posterior elements.
Okay, how about C3, C4?
Again, you have some susceptibility artifact. I think you get a little bit of uncovertebral hypertrophy and some neural foraminal narrowing. And some of that could be some facet arthropathy as well. But again, the susceptibility artifact obscures it. Spinal canal minimally narrowed.
9 millimeters. You think that's pretty normal?
Yeah, and it's narrowed. It's narrowed. I mean, you can kind of see, in fact, the dark line to the dark line above the M. The M is on a dark line, and then above it there's a dark line. So there, I would say that's about how much the canal is narrowed.
Okay, but look at the spinal cord here. It's got a nice, it looks like a little bit like a football. I say that because Nate's a big football player. But here, does that look like a football? That looks like the football maybe when Cook kicks it, when he punts it more, I would say. It doesn't look like there's a foot.
Slice of an orange. Slice
What do you
of
think?
An orange, slice of watermelon, maybe.
Yeah, but it always gets more crescentic in the mid-cervical spine.
Don't talk about food. I didn't have breakfast yet. Now hold on now. So this is where it doesn't look like a football, and yet here it looks like a football, and here it looks like a football, and here it looks like a football, but here it's got that flattened. So you think that's just normal?
No, it's narrowed, but it's not much.
Not much. But for us in the orthopedic and spinal literature, like 10 millimeters is like stenosis. Yeah, and the reason is just from anatomical subjects that the vast majority of people are bigger than that. So she's got a developmentally small spinal canal, and that's why she's probably had so many surgeries. And although there is this I think the thing looks deformed. Doesn't it look deformed or no? Like I have this cognitive dissonance every time I read radiology reports where they say it looks normal. When I look, that doesn't look like a football. Or no?
I don't know. My thought is it's within normal. I would say that shade is within normal.
But let me ask Nate, because he's not a medical guy, but Nate, does that look like a football?
Yeah.
And how about here? Does that look like a football?
It's elongated. Oh, no.
It looks like the football's been, if it's been compressed, like somebody's sitting on it.
Yeah.
All right. Okay, I won't belabor this point. Okay, so what do you think all the problem, everybody, let's name some problem areas. Amy, what's one thing that's wrong so far? We're going to try to fix her now.
The C6, C7.
C6, C7, non-union. Okay, Megan, what else is wrong?
The screws.
There's a screw maybe in the C3, C4 disc space, in the facet?
Yep.
Okay. Nate, it's getting harder now.
It's good.
Is there one thing that's wrong? What about your football? Come on, you're a football fan. The football may be compressed at C3, C4.
C3, C4.
Someone kicked the football at C3, C4, and that's not good. It's never good. It's never good when the football's punted, right? If you have the football. So, Doug, can you add any other problems? I think we got them all. So,
Yeah, she's opiate addicted, huh?
yeah, that's a problem too. So, okay, so what can cause pain following a recurrence of spinal surgery? Let's say you do a spinal fusion and the patient comes back, I'm hurting. Well, it could be a non-union and never healed. It could be adjacent segment degeneration of either the disc, the facet, stenosis. She does have C3, C4 stenosis, I think. And she does not have instability. Maybe the pain generator was never included in the fusion mass, so maybe she had a C3, C7, T1 disc herniation that nobody ever saw, and that's why she still has pain. But that's not her case. And then the other problem is maybe the pain generator is not in the spine. There's other things that can cause neck pain too. So pain is, just so everybody knows, pain is a subjective experience only understood by the individual. So it doesn't, you can have pain from all sorts of things, and they may not, Doug, you can attest to that, right? I mean, you see patients that there's no anatomical abnormalities that we can fix as orthopedic surgeons. It could be coming from anything.
Sure.
Okay. So this is, I wanted to show everybody this because this is an interesting case. This is a 55-year-old woman who I did an ACDF, C4 to C6 ACDF, And she came back post-op day 3. She said she was having a hard time breathing, and her neck was swollen. I was worried she had a hematoma of blood pushing into her airway. So I ordered a CAT scan to look at her airway. But in the midst of that CAT scan to look at her airway, we also got a CAT scan of the spine. She had allograft. So do you think she's post-op day 3? So Adam, is she fused?
No, because she's post-op day 3.
Because you know she's post-op day 3.
Right, but it sure looks like it.
Sure looks like it, doesn't it?
Yeah.
That's what it looks like immediately. Now, the same lady came back a year later and was saying her neck hurt. Now, does she look fused?
No, it's C67, she's not.
So what happened? Now, Doug, let me ask you, what happened? Why does the CT look different now? Why did it look so normal before? Like here, it looks totally fused. And why does it look so different now, a year later?
Well, when you put allograft bone in, it's cortical. It's almost the same density as the bone adjacent to it. But over time, it resorbs. It either incorporates or.
Why does it resorb?
Excuse me?
Why does it resorb? What does that mean?
It means that you get vascular ingrowth, you get osteoclasts, they chew up the bone and they try to replace it, and sometimes they just chew up the bone and don't replace it.
Okay, great. So let's go over this because I find these things kind of interesting. So this is a hip, right, guys? And it's so people think a hip, they think it's just like this rock, you know, like it's like a bedrock or granite, but it's not. Look, if you cut it in half, look at all that. What's all that? Tell everybody what that is, Doug.
That's cancellous bone.
This cancellous bone. It looks like a sponge, doesn't it? And it's alive. Like, tell everybody what all these things are, Doug.
Those are vascular channels.
And these things are what?
That's bone.
These are trabeculi, right? Trabecular bone, right here. So this, if you could take one of these tiny little strands of bone and then magnify it under a microscope, that's what it looks like. And in between here, what's all this, Doug?
That's vascular.
Either blood vessels, yeah, or there's some fat in here, or there's blood cells, you know, like hemo.
It's the body's reserve of calcium,
Yeah.
phosphorus, but then they're usually the osteoblasts are right.
Okay, so what are osteoblasts and osteoclasts? Here's an so this is the
Blasts
trabecular.
make bone.
Okay, hold on, let me just tell everybody what this is. This is the trabecular bone, even blown up even more. And these guys, we're going to say, are osteocytes. They're just chilling out. They're kind of quiescent bone cells. And these are osteoblasts. What do osteoblasts do?
Blasts make bone.
So the blasts make bone. We try to make things simple in orthopedics. And then osteoclasts?
Class eat bone.
Class eat bone. But why would you want somebody eating bone?
You're constantly remodeling. You eat the old bone, and it's called a cutting cone, supposedly. It's like an ice cream cone. And at the tip of it are the clasts, which chew up the bone, and they sort of leave a wake. And along that wake are the blasts, which come down and lay new bones. So the body is constantly remodeling the bone.
Why does the body remodel bone?
You grow.
But Nate's not growing. What about for Nate?
Nate's bones are growing. If they're not growing longer, what happens is as you get older and you lose bone cortex or thickness, your bones become more tubular, so they grow a little bit. They thin out and they get, the center of gravity becomes a little bit wider. If you break a bone, you have to remodel it.
Does everybody understand why the bones get big? Did you know that, Adam, that bones as you get older, they become the diameter gets larger? Because it's like they're like a column. And the strong, like if you take a piece of paper and you say to someone, make this piece of paper hold the 10-pound weight, you say that's impossible. It is. If you roll it up as a column, it's extremely strong. So the bone knows this somehow magically, and it can grow into a bigger column because it's strong. It has to hold weight. So it's the strongest form of a structure that holds something. You see what I mean? So that's why old people have these big bones. You know how we know it? We're not that smart. You know how we know it? Because we stick nails in old people, and old people, it just shoves all the way down there and they're easily like, wow, she's got a big bone. And why don't kids have it? Because they don't need it. They have really thick cortex. So the old people have a thin cortex, and the body knows to make a stronger bone that it gets bigger. Kind of interesting, right? Don't you agree with that, Doug? So okay, so what about Nate? Why when Nate plays on flag, because he likes to stay active, he plays on the flag football, and he comes home and his knee hurts, and he can't walk, and his wife's a little worried, and Nate goes, "I'm all right, it's going to go away," and then 3 days later it goes away. What was that? What was that, Doug? Nate's not crazy, totally normal dude. What was the pain in Nate's knee? inside the bone?
Inside the bone, it could be just excess pressure. He's just, running farther than he should be, and his bone hasn't remodeled to adjust to that pressure yet.
Okay, and the way I think of it is a microfracture. So he had if you got an MRI of him, if he was like Terrell Suggs and we get an MRI, the next day it says bone bruise. Well, what's a bone bruise? I think it's a trabecular microfracture. So one of these tiny little trabeculi, the little strand bone broke, and then it healed itself. And how did it heal itself? Through this process, through the osteoclasts and osteoblasts. They're constantly remodeling bones. So that's why even Nate, who's not growing, needs to have this process. So when this process is uncoupled, like in Paget's disease or all sorts of problems, it's a big problem when this process doesn't work well. Or osteoporosis.
We take Fosamax or bisphosphonates.
So this is just so we go. So this is the osteoblast laying down bone. And you can see this is the bone that it's laying down, the immature bone. And eventually, I think these same bones, they chill out here as osteocytes, and they give nutrients to the calcium. The part of the bone that looks hard is calcium hydroxyapatite. And the calcium is also a store of calcium in our bodies, and calcium is used in other parts of our bodies, like who can name some other areas? Like in our heart, and calcium.
Skeletal muscle.
Skeletal muscle, yeah, all sorts of things.
Calcium channel blockers.
So there's a constant use of this store of calcium from calcitonin and parathyroid hormone. So parathyroid hormone comes from the parathyroid hormone, which is like next to your thyroid, calcitonin from your thyroid. And when the body senses a low or a high calcium in the blood, it regulates it through the bone and the osteoclasts. So here's an osteoclast magnified eating some bone. And either it's remodeling it to make it stronger, like for Nate, or it could be the body needs calcium for whatever reason and is putting some calcium into the bloodstream. So here's a cutting cone that Doug talked about. It's a way to remodel bone. It looks like a sort of a cone, and the osteoclasts are in the front, and the osteoblasts are behind it, laying down bone. So the osteoclasts are drilling into the bone, and the osteoblasts are behind it, laying down bone. And here's a really great example of the cone. And here are the clasts in the front, sort of eating the bone away. And you can see it's eating the bone. And here are the blasts behind it, laying down bone behind them. And that's how we remodel our bones. So now this is different from a fracture. So what happens in a fracture? Where does the bone come from in a fracture, Doug? And let's say this is a kid, 5-year-old.
If the periosteum is intact, a lot of the new bone comes from peripheral around the bone.
How's that? What's periosteum?
Periosteum is the skin of the bone, basically, and it's this whole process, but that's how people's bones grow a little bit wider.
Mm-hmm. And the periosteum has bone cells. So here's the fracture. Can you see this is a bone that's broken? Can you guys see it's like a femur that's broken? You see the crack right here where it broke? Okay, and what's all this, Doug?
That's a fracture callus.
This is a fracture callus. So the periosteum's
bone being laid down.
And this is all new bone being laid down. And this is the periosteum here, and all this is like osteoblasts and cartilage is laying down cartilage, and it's a big wad of bone healing, and then it all fuses together to be a bone. And then through the cutting cones, it all remodels. Through the cutting cones, it remodels into a normal-looking bone. 10 years later, it doesn't look like that.
I was going to say, it doesn't have that.
No, 10 years later, the thing, you don't even know it's been a fracture there in a kid.
3 years later.
Yeah, probably 3 years though, yeah.
Is there any tendency to correct angulation?
Yeah.
So there's a propensity to straighten.
Somehow the body knows.
Again.
Yeah. Somehow,
like
hey Raj.
It has a compass or whatever.
Yeah, well, thanks for coming, Raj. Yeah, somehow is it compass or how? Why is that? Why do bones remodel in kids? Because you're late, you have to answer a question. When there's a child like a 3-year-old who has a fracture, like you take call, right?
Yes.
And you'll accept like a 20-degree angulation in a kid, a 3-year-old, and then when he comes back in 6, it's normal. Why? How does a bone know to grow straight?
I guess not exactly sure the direction of stress. The bone grows. The bone, I guess, the callus grows in a certain way to strengthen the bone to accept the most stress, the base load, and I guess the way it's loaded.
Yeah, nobody knows, right? So the forces across it are the piezoelectric forces when you walk and when you move your limbs. Somehow there's a diagram somewhere where the bones know what they should look like, and they form that, right? It's weird. Like, what things do you never accept? What type of things don't work well in kids? What type of deformity does not remodel that you know is not going to remodel?
The
Rotational deformities, yeah. So that does not remodel for some reason. And also in kids, if the fracture is near a growth plate or far from a growth plate, which one remodels better? Near growth plate, yeah. So there's more plasticity or who knows what. So these are all little things that we know of taking care of fractures. Okay. So who gets a non-union? Is that okay to put our commander-in-chief with the cigarette?
He smoked?
I thought he quit. He quit.
Well, he did smoke.
He did. Yeah, he was probably had a couple drinks here. And someone snapped him. Yeah, he was at a Chicago labor union meeting, and he had to fit in. Took his tie off and just took a couple puffs. So who gets non-unions? Metabolic disorders, cigarette smokers. Doug, why do cigarette smokers get non-unions? Because patients don't believe me when I say if you smoke cigarettes, your bones won't heal.
You get less blood supply.
So somehow,
Vasoconstrict.
yeah. So somehow the nicotine vasoconstricts at the level of the fracture, and they don't heal. Doug already told us infection's a risk. Excessive motion. Remember we said that at the base of the implant there's a lot of stress. If you don't instrument it, and there's more motion. Allograft. Wouldn't you say it's a higher incidence of non-union than autograft?
Yes.
Okay. So L5S1 is, again, it's the base, and I put hip arthritis is for lumbar spine is a risk factor for non-union because they don't move through their hip, so they're more likely to move through their spine. So there's a higher likelihood of non-unions in the lumbar spine. Okay, my name and anything else? You don't have to. So where can you take
non-union?
Huh?
People with previous non-unions
are more likely. Yeah. So this lady that we're going over, she's at risk, right, for that, and it's at the base. So these are all the options we have to fuse. We can use iliac crest. We could use local bone graft that we cut out of somebody while we're operating. We use allograft, which is from a dead person. It can either be morselized or structural. We can use bone morphogenic protein. We can use demineralized bone matrix, and we can use ceramics. These are all options. And these are the options for anterior cervical fusions. I think this is what she had before. This is like a piece of fibula. It's all cortical. These composites I think are better for some reason. They're cortical on the outside and they're cancellous on the inside. So I think they're more of a physiological shape than these. And these, I think, I look at these things that they have to go through this tremendous remodeling process to become normal. Because look at all the cortex here. And that's why Adam called it a spacer, because it looks like a piece of plastic. While these, I think, because of the shape of the trabeculum, are higher likelihood to fuse. I don't think this has been studied. And these are all sorts of PEEK and plastic things that people stick in as well. And there's tantalum. Do you use tantalum, Raj? You're a joint expert.
In the hips, we've gone to using tantalum in revision situations and where the cup hasn't grown in on the second surgery. It's a little bit more expensive. It's very porous, and the pore size enables the bone to go into it.
So the bone grows into these pores through the tantalum, right?
Yeah.
So here's the tantalum right here, I think.
Those peaks, you're plugging something into those gaps, right? To help facilitate growth or no?
You're supposed to put bone in them.
Yeah.
And the bone grows through the holes.
Yeah.
PEEK is, there's nothing special to it, it's just an inert substance.
It's a structure, right?
Yeah, it's just a structure. So this is a case. I didn't send you guys the article because only Doug reads them. Then he asked me questions, and I don't feel like he answers questions, so I didn't send you guys the articles. But this is a recent article in 2010. I'll send it to Doug after the conference, so I don't have to answer the questions.
I read it already.
You read it already? It's adjacent segment degeneration. So this is a guy who needed surgery, and this is 10 years later. He had the surgery, and he's getting adjacent segment degeneration here. The level higher is going bad. And this is a guy who never had surgery, and 10 years later, his discs are going bad too. So the question is, when people get adjacent segment degeneration, they have a fusion, and the next level goes bad. Is it because he had a fusion and it's stiff, or is it just a natural disease process? And no one really quite knows, although this is very hot in the literature now because of disc replacements. So the focus of disc replacement, cervical disc replacements, is that your motion is retained. But whether that's actually true, no one quite knows. But this whole thing has been driven by a secret process. Does anybody know the dirty little secret? Tina?
Companies that
The vendor.
Huh?
The vendor.
Yeah.
Yeah. What about, do you know, can you sum it up? Does anybody know the dirty secret? Nobody talks about it. It's a total secret in society. In fact, maybe I shouldn't say it.
Well, if
Huh? Okay,
they sell products.
I'm gonna
Don't say it online.
It's okay. It's not bad. I'm just kidding. Okay, this is the dirty little secret. The hospitals make a big profit from spine surgeries, right?
Yeah.
The implant companies know that. So they're going after that profit, that extra cash that the hospitals have, by increasing the costs of cervical surgery from $3,000 to $10,000 with the disc replacements. That's the dirty secret. See what I'm saying? And it's a victimless crime.
Outcomes are.
It's a victimless crime. The hospitals don't care. They're like, we're still making money. We make $1,000, not the $10,000. So we can't build the OBGYN wing. You see the dirty little secret? And everyone's trying to, huh?
We're not making the selection. We're not making the choice.
The surgeons are. So the implant companies, Medtronic, Johnson & Johnson, Stryker, Synthes, they're just going after us like crazy.
So we're a byproduct of the benefit.
Does anybody disagree with me, or what do you think, Raj? You're laughing, right? You don't think about stuff like this? You're a young guy.
I haven't thought about that.
Nah, young guys don't think about it. What do you think, Doug? Am I right or am I wrong? It's just for patient care, disc replacements.
I think you're building a conspiracy theory.
All right, I'll forget. I'm Greek. Greeks love conspiracy. I'm Greek. Greeks love conspiracy theories. We'll just drop it. So so we'll go back to our case. So she had a revision anterior surgery, and I took down this non-union. These are my notes for the case. I took this plate and screw out. It came out pretty easy. And then I drilled away all this allograft bone, which was an obvious non-union, and I know that because it was moving during the surgery. I put screws across at this space, and I could see it shift. And I went all the way down to the posterior longitudinal ligament, but I didn't expose the dura because I didn't think we needed to do that. And then I put iliac crest. Are you shocked? Are you shocked, Raj? Did I use iliac crest?
In a non-union situation, I think that's the way to go.
Why is that?
Because somebody's already tried the non-iliac crest and they healed, so.
That's what I thought too. And then I also did C3, C4. I fused it because I thought she was relatively stenotic, and it was the only area that was open. And the screw, like Adam said, may have been hitting it. So now she's solidly fused from C3 to C7. And she woke up and she said her neck felt better. So is this a total success now, post-op day 2?
Sure. Until she gets back.
Huh?
Absolutely. Send her to someone else quickly.
So what do you think here? The X-rays look okay, Adam?
Well, you still have the posterior screws that are loose, and the one.
Wait a minute, cowpoke. Are they really loose? Because you said they're fused. So there's no motion across them.
The facet is
You see, across here, at some point in time, there was motion, and they were loose, but then it fused. So if it's fused, they're not going to move. They shouldn't move. See what I mean? At some point in time, it wasn't fused.
I see your point.
But it did go on the fuse, so it's not really that much of a concern.
All right.
There's almost no
And
chance.
What about that screw that extends into the facet joint?
I fixed that. Doug, tell him how I fixed it. How did I fix that?
Oh, your fuses.
Because I fused in the front.
Yeah.
So she's not going to move. So now she's solidly fused from C2 to C7. And is she going to, and here's the post-op CT. She got a post-op CT because she came back post-op day 6 and said her neck was swollen. So I ordered a CT scan to make sure she didn't have a fluid collection. Do you see anything bad in her neck?
The prevertebral soft tissues are thick, but you were in there pushing them aside, so they should be.
Yeah.
There's gonna be some thickness in there.
Is this a critical airway issue,
No,
do you think?
not at all.
Yeah, I didn't think so either. So we just admitted her for steroids and elevation, and she resolved. But here you can see the iliac crest fused. So do you think that she has a stiff neck? Let me just ask you guys a question. If you fuse, let me ask Adam, because I like to mess with Adam. Adam, if you fuse from C3 to C7, is the patient going to be stiff? What do you think? This is loaded.
It's a relative thing.
Stiff is not an accurate description.
Yeah, I mean, she'll have,
Patient's going to have a limited motion.
You think it'll be limited?
Yeah, but the question is, how much is it limited? You know, I mean, classic teaching is you get like 50% of your flexion and extension in the upper 2 or 3 levels, and you get 50% of your rotation in 2 or 3 levels, and everything else is just like, so you know, a lot of these people, if you're operating on them, theoretically, hopefully they have limited motion to begin with. You know, they haven't moved their neck and.
Yeah, usually these...
Neurosurgeon, they probably haven't moved their neck in about 3 hours or something, so they need to be.
Okay, I'm going to show you guys something. This lady had a C3 to C7 fusion. You see it? This is in the office. She should be pretty stiff, right? Don't you think? All right, now I'm going to show you something.
Stiff, more subjective sensation.
I'm not going to get into a philosophical discussion with you.
All right.
So here she is. She's talking. This is you can see all this on Spinant, my Spinant YouTube video.
Yeah, she signed a release.
I got verbal consent. She also signed the. I also got a release. All of our operative consents. This is our motion. Look to the left. How much loss of motion do you think she has, Doug?
15.
15.
Rotation for.
How about that one?
I think she has full range of motion. You know, if you have
Between
less than
C2,
40
C1, and C2, and the occiput. Look at her flex down.
If you have less than
Look at
45
that.
She
degrees,
can't touch her chin to her chin.
Can you? I can do it, but it's not easy. Doug, well, Nate's young.
60 degrees.
Amy can do it. Can you touch your chin? Amy can do it because she's a young woman. But me, I can just barely do it. How about you? Can you do it, Doug?
Yeah, I can.
You're old.
But you know, if you look at the classification of disabilities, 60 degrees cervical flexion is considered normal. 70 degrees extension, 45 degrees rotation, and 30 degrees side bending.
30 degrees bend. I can't sign bend. My neck hurts when I do it.
So, you know, you tell people, you know, can you touch your ear to your chin? You go, yeah, sure, I can.
I can't even get close.
Do that, you know. But I mean, so, you know, there's a difference between stiffness and limitation of motion. You know, some of these people, like, I don't know if your neck has a limited range of motion, but some of these people, you know, they come in, you know, they're like clipple file or something. They haven't moved their neck in 50 years. You know, are you stiff? No, I'm not stiff at all. You know, can you move it? Yeah, here it is.
Well,
so I think stiffness is more a sensation of, you know, pain associated with limited motion. But a lot of people have limited motion without stiffness.
all right,
There's lots of reasoning for stiffness. I mean, swelling, edema, tight muscles in general can cause.
It's something Spiro doesn't understand.
stiffness.
Stiffness, yeah. Stiffness.
You know what? I have a bunch of other cases, but we're out of time. So no, I'm not going to go over this.
I'm surprised you went to anterior to where the problem was on that cervical nodule.
Why are you surprised?
A lot of people. Going to the front, revision surgery is difficult to the neck. A lot of people just go to the back.
I have a secret weapon. Do you know my secret weapon?
What?
Otolaryngology. So I got Dr. Day to help me.
Okay.
But you know what? There's another thing about anterior cervical surgery. It's not that hard. There's usually very easy.
Primary surgery is pretty easy, but
No, the revisions are very easy. I don't know why. If you ask any spine surgeon, they'll tell you this. Revision anterior cervical surgery, the anatomical landmarks are usually very, very good. And there's very limited scar compared to like posterior surgeries for some reason. And no one knows for sure why that is. Like if you do a posterior revisions, there's a ton of scar. But anterior, there's very little scar usually. I think the reason is the neck has a lot of motion. And I think the approach is not through a compartment. And it's between fascial planes, and because of that, they don't get that much scar. But still, this was her fourth case, so I didn't want any chances. I had otolaryngology help me, but I felt I had to go anterior because
it's the best way.
this is the best way to take that allograft out and then put in a new fusion. So, any other questions or comments? All right, thanks everybody for coming. See you next year.
Spiro, I had a CT scan earlier.